moderators, dear colleagues, thank you for inviting. I am an interventional neuroradiologist, and I'm happy to be here with you today. We are discussing about pain. I will excuse you because my topic is in Albanian, but I will speak in English. We are discussing about pain. Sometimes the pain is a syndrome, sometimes the pain is a symptom. It is not clear when it is one or when it is the other, but as the professor explained before, when it is a tarsal tunnel, it is for sure that it is a syndrome and we need to treat the cause. But when it is a symptom, like in the lumbar pain, we need to treat the symptoms. So, a little bit of anatomy. In this schema, we can see the causes of the back pain, which may be the vertebral bones, or the discs, or the fascial joints. And the physiopathology is simple. When the fibroid is teared and the liquid comes out, it compresses the nerves and creates some inflammation, which may be the cause of the back pain. So we can use the infiltrations of black nerve roots using the CT scans like a diagnosis, and in these cases maybe the pathology will be in multi-levels. Maybe we may have an antagonism between the localization and the clinical symptoms, and in these cases we can use the nerve root infiltration to make the diagnosis. When in the clinical examinations we don't find any cause of the pain, when the neurosurgeons ask us because they want to examine something and to have the clear aspect of the back pain, or when the pain it continues also after the surgery. And we use the block nerve root like a therapeutic indication when we want to pursue the conservative treatment, when we have contraindication of the surgical treatments, when the recuperation after surgery is prolonged, when the persistence of the pain is also after the surgery, and when the treatment of the mouth is not possible. So this is a schema that we can find in the literature about the causes of the chronic back pain. So there are 3 steps when we inject the miscellaneous of corticoid and anesthetic. So in the fascial joint, in the sacroiliac joint, and in the nerve root. And these are combined one with another if we don't have the results that we want to have. And the point of the anatomy in the anatomic view is that the injection is always done one level below the cause that we see in the CT scan on the MRI. So, as we are familiar about the anatomy like a radiologist, we know that the nerve root is always accompanied with the artery and the vein. So we have the capabilities to do the injections and to be careful not to damage the artery and the veins. And so this is very important for the radiologists to know before making these procedures. So this is an example. It is very simple for us with the patient in the CT scan to put the needle and to inject inside the facet, and these are images that we are familiar in our everyday works. If in cases of if a surgery is previously done. Like in this case, when the CT scan is giving a lot of artifacts, we can use the X-ray, the conventional X-ray machine and we have some markers like a schema of a dog when we know when to inject the corticoids to help also to relieve a little bit the pain. And this is another case, a simple case, when we can inject inside the fascia. In this case, often for diagnosis of a discal hernia in the L4 left nerve root, we can inject easily in the CT scan in the origin of the nerve root and inside in the epidural space when the diagnosis is made about the hypertrophia of the longitudinal ligamentum. And these are other cases of the techniques. It is very easy and very simple, and the results that we discuss with the colleagues are very correct. What we want to know about, like radiologists, is to know how to use the corticoids and the anesthetics before we do the injection, because it is not only the technical part that it is very important, but is also to be familiar with the drugs. And the corticoids that are in the market, as we know, are methylprednisolone, triamcinolone, and beta-prednisone and dexamethasone. And what we use is the triamcinolone that we have the best results on the injections. The hexatrione in 40 milligrams is what is approved now everywhere, and we will use this in combination of local anesthetics. What the dosage to be known is for low fasciates, for low joints, is as marked in the books. So what we have to be aware is the contraindications. So as we know, is the sepsis or bacteremia and intraarticular fracture, and relative contraindications are osteoporosis, coagulopathy, and not to inject more than 3 times in a year. In the field of anesthetics, so what we use is the marcaine, which, as we see, has the most prolongated time and the most duration in these combinations. So, in conclusions, I want to say that we make these procedures after discussing with our colleagues in the community team, with neurologists, with neurosurgeons or orthopedics, and knowing how to use the drugs like local anesthetics and corticoids is also fundamental for in our field of radiology. Thank you.